Hello and welcome to this month's Simon Says Expert Series. My name is Archana Kanetkar. I'm a physical therapist with IU Health, and I've been part of the programming for that supports patients with cancer here at the IU Simon Cancer Center. It's well established that rehabilitation interventions are very effective in managing physical impairments with cancer, especially when they are accessed throughout the continuum of cancer care. We call this the prospective surveillance model. And what that essentially means is when physical therapy, occupational therapy, or speech therapy are utilized right from the diagnosis all the way through survivorship, then there are better outcomes, better long-term outcomes as it relates to function. And with new research now, we have effective ways to manage things like cancer-induced peripheral neuropathy, which is our topic today. As treatment for cancer advances, the prevalence for neuropathy increases. And so it's very common for anybody who has, lives with cancer or beyond cancer has had some experience with it. So joining us today to share her expertise is Stacy Weber. She's a physical therapist who specializes in treating patients that have been impacted by all types of cancer. She spends time each week devoted to improving the oncology rehab programming for the IU Simon Comprehensive Cancer Center. She also supports the multidisciplinary oncology vitality and exercise program, which is known as MOVE. Stacy is a board-certified oncology clinical specialist, as well as an active contributing member of the oncology section of the American Physical Therapy Association. She has completed her oncology residency in Michigan, and she has also been certified as an oncology specialist by PORI, which is the Physiologic Oncology Rehabilitation Institute, kind of considered a gold standard when it comes to training with oncology. Stacy, thank you for joining, and I know that you have a ton of information that you are ready to share with our audience.
Thank you, Archana, for your introduction. I am going ahead and share some slides for this presentation. So to begin, I would like to define what the nervous system is. We need to know and understand the system that we're going to be talking about today so that we have a better understanding of how it impacts each person uniquely, as well as the body and our daily activity. So the National Cancer Institute defines the nervous system as the organized network of nerve tissue in the body. It includes the central nervous system, which is the brain and the spinal cord, and the peripheral nervous system, which includes the nerves that extend from the spinal cord to the rest of the body and the other nerve tissue. So nerves that travel throughout the body is what we'll be looking at today. Here we have a little bit more specific, the parts of the nervous system. Like I said on the previous slide, includes the brain and the spinal cord as the central nervous system that you see colored in pink here. And then in yellow on the diagram is the peripheral nervous system, which is the nerves that extend all the way down to the fingertips and the tips of the toes in the body. And they help communicate messages for movement, sensation, and other body processes and functions. The system is kind of a two-way highway system in the body that helps with that information going from, say, the hand back to the brain, as well as another way to think about it is like a phone wire where it communicates information between two different areas. Further, in the peripheral nervous system, those areas where the nerves are impacted, I want to describe the image here as the functions and the roles the nervous system is responsible for. So it helps connect the central nervous system to the organs, limbs, and skin. It helps carry that sensory information, kind of the feelings that we have on our skin, and then the motor information, which is more of the movement we do with our body, moving your arm, moving your leg, and helps take that information to process back in the brain and the spinal cord. Kind of here with the brain, like I said, that helps with that communication between those areas. And we need that to happen to allow movement to happen, or those body functions such as the heartbeat and breathing. The nervous system has these responsibilities that help us carry out our daily activities and the things we enjoy doing in our homes and communities. Further, for cancer neuropathy specifically, we have two definitions here that are relatively similar, but from two different well-known cancer organizations. So the National Cancer Institute and the American Cancer Society. Both of these really describe neuropathy and peripheral neuropathy, which is what we'll be focusing on in our presentation today, as problems with the nervous system that can cause pain, numbness, tingling, swelling, or muscle weakness in different parts of the bodies. And it usually begins in the hands or feet and gets worse over time. We know that neuropathy can be caused by the cancer, the disease itself, as well as the treatments that we used for cancer, especially chemotherapy. We know that this happens as a physical injury or damage to the nerves, as well as sometimes infections can cause it, other toxic substances, and conditions such as diabetes, kidney failure, or malnutrition. So I just wanted to highlight in both of these definitions, they are very similar, but today we're going to be focusing primarily on chemotherapy-induced peripheral neuropathy. So we know some different facts as well about this kind of neuropathy. It is very common among people living with and beyond cancer. We know somewhere in between 50 to 90% of patients receiving certain neurotoxic chemotherapy drugs have signs and symptoms of CIPN. And I'll refer to chemo-induced peripheral neuropathy throughout this presentation, mostly as CIPN. But the reported statistics vary somewhat with that range of 50 to 90% because patients may not know that's what they're having going on and it might be underreported. But then also we know people are living longer because of the advances in the treatment that we have available for cancer. So how does it occur? We understand the development of CIPN depends on which type of medication a person receives and how much of that specific medication. So we know that there are certain drugs that can cause it, and it depends on how long is somebody receiving these, how many cycles of that chemotherapy or other infusion drug are they receiving, as well as the actual dosage of it. In some cases, if a person develops neuropathy, their oncologist may reduce the dosage of that drug. Sometimes patients may receive a 25% dose reduction or a different percentage determined by your oncologist. But that means they're not receiving 100% of the dose they were expected to initially have due to the development of neuropathy. And sometimes, if it's severe enough, they may stop administration of that drug completely. With CIPN, we know the peripheral nerves, so the ones that are outside of the brain and spinal cord, are the ones that are injured or damaged. And we can kind of see that a neuroinflammation happens where there's some inflammation at the nerve that causes changes in those messages between the nerves that are far out in the body back to the spinal cord and brain. And the changes that we see include autonomic, which is the involuntary functions, which I previously mentioned, such as internal organ function like the heartbeat and breathing, as well as sensory information, so what you feel on your skin and on your body, as well as the motor nerves, which are the nerves that are responsible for producing the movement that we complete. So standing up from a chair, walking around, going up and down the stairs. And further on the next slide, I'll detail this a little bit more. So here we talk about how does it look and feel. Some of those autonomic symptoms are on the left column here. These tend to be more rare for people and aren't quite as noticeable for some. But people can have issues, again, with those involuntary actions that we have in our body, those processes that happen kind of naturally, such as issues with the cardiovascular system, so the heart, as well as the blood vessels throughout our body, which can sometimes present or look like low blood pressure. People may also have difficulty with going to the bathroom, so urogenital problems there, including sexual function. Patients may also experience some problems with their stomach, so not being able to digest food appropriately, not being able to process that food, and then even have difficulties sometimes with emptying their stomach, so using the bathroom, or some patients may experience some nausea or vomiting as well. Some of the motor symptoms that we see, which are more common, are the muscle weakness itself, so just muscles not being as strong as they were prior to receiving chemotherapy, as well as muscle cramps, so more of like an achy, crampy feeling, similar to if you think of like a Charlie horse, but usually in both legs or even sometimes in the hands and feet. And then reduced motor reflexes. So if you think of when a doctor may have tested your reflexes in your knee, some of those reflexes in the body can also be diminished with neuropathy. And the third column, we have those sensory impairments that we also often see in what people typically refer to as the pins and needles feeling, burning, prickling, numbness. With neuropathy, this varies quite a bit for each person because of the different types of medication that are used for chemotherapy, as well as the dosage. So it's very unique to each person for this reason. And patients may describe it different than these couple of descriptors I provided here. Sometimes people feel like there's something in their shoe and there's nothing there, or they might say they feel like they're walking on gravel. I've heard a lot of different ways that patients have described it, which really just highlights how it is so unique to each person. With that, patients may experience a hypersensitivity where something that shouldn't be very noticeable is very noticeable and very over-exaggerated almost for a patient, or possibly more painful for something that is not a painful stimulus. And then on the opposite side of that, some patients may have numbness where they have very little or absent sensation altogether. Other sensory symptoms include ataxia, which is trouble with coordination, and then also some trouble with fine motor skills, such as handwriting, typing, using small objects. So from here, we know that from research, we have found several types of chemotherapy that cause peripheral neuropathy. We specifically know the platinum group of drugs, including cisplatin, carboplatin, and oxaliplatin, as well as taxane drugs, which includes paclitaxel, docetaxel, and Abraxane, as well as the vinca alkaloids, which include vincristine and vinblastine. Those are the chemotherapy drugs. A couple of other infusion types of drugs that are used are some targeted therapies. One that they use often for multiple myeloma is bortezomib, also known as Velcade, and different immunotherapies, again, kind of used for multiple myeloma, thalidomide. Several of these drugs are used very regularly in the treatment of breast, lung, ovarian, colorectal, and gastrointestinal cancers, as well as testicular and blood cancers. So often these are being used as like the first line of treatment for several of our cancer disease groups. And again, that's why we see such a high prevalence of chemo-induced peripheral neuropathy. So many patients with a variety of diagnoses can experience CIPN, especially if they are receiving any of these mentioned drugs here. Further here, we're going to look a little bit more at the anatomy of a nerve cell and all of the small parts that are impacted by specific medications as listed in the diagram. So on here, this is what an actual nerve cell looks in this is a diagram of one, but a small nerve cell has all of these different little organisms and parts that help with our function in our bodies for our nerves. And we see, again, these different areas are impacted. So depending on the medication or chemotherapy somebody receives, different symptoms will occur because of these different areas that are impacted. And we know that each person really has a unique way that they feel neuropathy, but all of these different areas have been documented as having injury somewhat from the chemotherapy. So then we'll go a little bit more into the treatment timeline of what does it look like when somebody is developing chemo-induced peripheral neuropathy, or when will it start more so. So Within even the first month of receiving treatment, a person may develop some of these things that we've talked about, the weakness, the numbness, tingling, pain that they hadn't had before they had the chemotherapy. Again, it is highly dependent on the amount of the specific drug the person receives, as well as if they are receiving more than one of those drugs. In some cases, patients may receive not one, but two different types of chemotherapies that are known to cause these neurotoxic side effects. Sometimes the symptoms may resolve within the 6 to 12 months following the completion of cancer treatment, but symptoms can last longer. Other risk factors include having diabetes beforehand, and that sometimes diabetes itself people can have peripheral neuropathy for. The most important thing is if you're noticing these symptoms that you get referred to physical therapy as early as possible to try to work on some different things to improve your quality of life, your daily activities, and just your safety and independence overall. Some questions you might ask yourself that might be signs of CIPN include, am I having weakness in my hands and feet? Do I have trouble getting up from a seated position? Is it hard for me to use buttons on clothing or pick up small objects? Has my handwriting or typing changed? Do I feel more unsteady or clumsier when I'm walking inside or even outside? Am I tripping when I'm moving around? Do I have painful feelings in my hand and feet? And do I have numbness and tingling or a pins and needles feeling anywhere? As well as is it hard for me to tell if something is hot or cold in temperature? So really all of these things, again, kind of help us understand if somebody is describing these things. These are some ways that lead us to understand if a person has the chemotherapy-induced peripheral neuropathy. Then we talk a little here about how is it diagnosed. So first of all, we need to understand if a patient has had a known chemotherapy drug that causes these toxic symptoms. So thinking of those platinum-based drugs, the vinca alkaloids, and the taxane groups especially. We'll see a lot very often from those groups that patients have this. But we might also notice outside of that, just from their day-to-day activity, if they're having changes with their strength, if they're having more difficulty walking, and if they're having issues with balance. So definitely if patients are experiencing unsteadiness or if they're falling and they were doing fairly well in independent moving around before they had chemotherapy, that can certainly be a sign that they might have neuropathy and they're having trouble feeling the bottom of their feet when they're walking or maybe tripping, if they're having weakness as well, or just difficulty in being able to tell where their foot is on the ground. So for us, again, with diagnosing, your providers, your medical team may order additional testing to see how the nerves are functioning, but we might also do in the clinic for physical therapy, a neurologist or oncologist, as well as other medical professionals, is testing the sensation in the hands and feet. So we have small tools that we can use to test what we call protective sensation, which is somebody's ability to feel a very light touch on their foot or hand. And we just use small tools in the clinic to test that and see if somebody can feel it. Additional things that we might do is testing strength. And then also on here, I have the reflex hammer. So again, being able to test those reflexes. Does somebody have the reflexes or are they absent or are they not there? Here, I'll talk a little bit about what does the medical team, so more of the doctors and providers who are on your oncology team, what will they do? So sometimes they'll use different medications, and there is some research that shows that the only medication right now that we've identified to assist with pain relief really is duloxetine, which is known also as Cymbalta, which may be prescribed by a doctor. That is considered the current best practice from the available research that we have. But I will also see patients who have had medications such as gabapentin or pregabalin prescribed as well from their doctors to treat the neuropathy pain. To differentiate, we'll talk a little bit more here about what kinds of physical therapy treatments that we would do for CIPN. For each person, it's really going to be tailored to them, again, because of that uniqueness of neuropathy for each person. But our main things that we'll focus on are manual therapy, desensitization techniques, strengthening exercises, balance activities, and then patient education. Additionally, I just want to highlight we continue to have ongoing research and always need more research about how to impact things such as neuropathy. But these are all things we can certainly work on with patients before, during, and after cancer treatment that can help improve quality of life, daily activity, and maintaining independence with just your daily activity as well as your hobbies and things that you enjoy doing in the community. On this next slide here, this image is from a systematic review from 2022, and a systematic review is considered our highest level of scientific evidence. In this image here, it explains pretty well what we know so far for the rehab, exercise, and non-pharmacologic interventions. So these are interventions that you might be able to do with a physical therapist, an occupational therapist. These are things that we would do instead of using medication or may complement if you're taking different medications prescribed by your doctor for nerve pain. But we have kind of the three slides here, or three columns here. I will say first in the center, it shows the image of the patient with CIPN. And I really like this image because it shows the areas that are impacted the most. So the tips of the fingers, the tips of the toes and the foot. And really patients will typically tell me when they have neuropathy that they feel it on the palm side of the hand. So starting in the fingertips and going downward towards the palm, more so than the back side of the hand, as well as on the bottom of the foot, which touches the ground, starting from the toes and going up towards the heel. In this image, we have that reddish orange color that's darkest, like I said, in the fingertips and the toes, but then it kind of changes into a gradient where it's not as severe typically or not as prominent to the patient in the legs going up towards the knees. That color gets lighter and there's less of those feelings of discomfort or burning and tingling that people experience. They describe it as a stocking and glove pattern. So you could imagine if you were wearing gloves or socks on your feet, those are the areas where are usually impacted. And then I will talk a little bit about the prevention here. So with the systematic review, they reviewed a lot of different articles that have been written for research that has been completed for these different interventions for CIPN. The level A evidence would be our highest level, most consistent evidence. And then level B, which we have a couple of things on this slide in those blue ovals, are level 2 and 3 studies, which are consistent as well. And then level 3 studies and level 5 studies are the yellow and orange, respectively, where we still need some more evidence on being able to recommend these. But these are all certainly things we can work on. So we have the most research for exercise, endurance, and strength training as far as interventions for treating chemo-induced peripheral neuropathy. And we actually have its moderate level evidence to show that we can help slow the progression of CIPN during cancer treatment as well. So those are the things that we will work on. We can help patients understand different exercises to kind of help slow that process down. And then that also includes some of the work we do in physical therapy, which is also balance and sensory motor training. I'll talk a little bit more about these on a future slide. And then there's also some evidence, that level D evidence for massage, electrical stimulation, cryotherapy, which is cold therapy, and compression therapy. So those are all in that left column, the prevention column. And then for treatment, we also see balance and sensory motor training again as one of our main things that we'll focus on. And we have in yellow, they have the electrical stimulation. I'm sorry, that's in the orange. In the yellow, we have exercise, endurance, and strength training as that smaller yellow oval, as well as the neurofeedback. So that again would be some work we would do in the clinic with our patients, working on improving your understanding really of how your body feels now if you have the neuropathy, and kind of teaching different strategies to help regain balance, to help kind of understand again where are you in space as well. And then the orange again on this slide, we have massage therapy as an option, or types of techniques we would do with our hands, electrical stimulation, and then they kind of generally have other physical therapy. So things we would do in rehab, which I'll describe more now. So for manual therapy, again, that's something we would do with our hands. A physical therapist or sometimes occupational therapist will do these techniques to help reduce pain and may also help with calming the nerves in the hands and feet. So I described earlier with neuropathy that there's damage or injury that occurs in a type of neuroinflammation, really. So these techniques can help us improve blood flow to the area and help to kind of calm down that irritation that's occurred at the nerve. And this includes massage techniques that we also call soft tissue mobilization. In my own treatment practice as a physical therapist, I follow a technique I learned at our national PET conference within the last couple of years. And not all physical therapists have received this training, which is why it's really important to work with an oncology trained physical therapist. Similar to the medical treatment or radiation treatment that a person may have for cancer, you would go to a person who specializes in oncology or cancer, as well as your specific disease group. But rather than going to like your primary care provider, you would go to an oncologist. So similarly for physical therapy, you would want to see an oncology trained physical therapist who more so understands the disease of cancer itself, as well as the specific group like breast cancer, colorectal cancer, lung cancer, and has a good understanding of the different types of treatment that are used for those diseases in cancer. So typically for the manual therapy I perform for my patients that I learned from that conference, we work on the front and the back of the hands, as well as the top and bottom of the feet. And then we teach part of this to patients and or somebody that they bring in with them to the session, maybe a significant other or a caregiver, and then have patients really focus on doing this 2 to 3 times a day, especially in the morning to kind of help loosen up the tissues, and at nighttime. A lot of times patients will also describe their neuropathy feels worse at nighttime, so that's a really good time to work on this technique. And then using a gentle unscented lotion with minimal ingredients added. And we know, again, from the research that we can see an improvement in quality of life in reducing that neuropathy pain that patients experience, which can be quite significant. It can be tough on somebody day to day if they're always feeling like they have numbness or tingling or that burning sensation. So this is one of the main tools that I use in my practice with patients who have neuropathy, is this manual therapy technique to help reduce that painful symptoms and sensations that patients have. Additionally, we have different desensitization techniques where we will use different equipment or tools and different textures in the clinic, and even teach patients how to do these things at home to help improve that communication between the nerves and the brain. Similar to what we do if somebody had surgery and we had a scar that we were trying to work on. Sometimes we call it scar desensitization, where we'll introduce pieces of fabric, such as soft fabric, starting with really light, gentle touch, using maybe a cotton ball or a piece of satin, and then progress towards using a little bit rougher items like a towel, or sometimes we'll use different things, even kind of immersing the hand or the foot in a bowl or bin of things such as rice, oats, beans, or marbles, and sometimes even beads. But these are to help stimulate that tissue and help to reintroduce and re-educate the nervous system. And again, for immersing your hand or foot into something, we would make sure there's no open skin areas where something could get into that area. Overall, these are things that we would encourage a lot of consistency with, because repetition is needed to help repair those nerves and kind of those neuro highways that I described. Nerves can grow and regenerate. They're just one of the slower tissues to do that compared to other tissues like muscles in our body. Of course, as I said, strengthening exercises are one of the things we will do a lot with as well, to help improve weakness that somebody might have. And weakness is certainly a very common side effect with chemotherapy, and that patients may specifically have with neuropathy. And we will help again by improving blood flow to the area that's impacted and just increasing a person's overall strength to keep them more steady on their feet, to keep them moving and doing what they enjoy, and to help maintain that independence that we always want to see with our patients. In the clinic, we'll guide patients for strengthening really for the whole body, and then also provide handouts and a home exercise program so they can work on this as well at home. Because again, like I said, the consistency in maintaining and doing repetitions is very important in helping optimize and kind of helping regrow and reteach in the body with the nerves and even the muscles. Similarly, we will work on in the clinic is balance activities and sensory motor training. So we will do different things where first we'll test in the clinic our patient's balance to see what kinds of things are they having trouble with. Are they able to do static activities where they're just standing in one place, or are they able to do more movement and maintain their balance? There's a specific test that I do in my practice that is recommended for all adult survivors of cancer. And we look at about 10 different things, some things that are more standing in place, trying different things like standing on foam, reaching, and then also some more advanced things like walking and doing head turns, or walking kind of like on a tightrope. We call that tandem walking. As well as we might test single leg balance to see how is somebody able to do if they're standing on one leg, which is an important task because we need to be able to do that if we're going up and down the stairs or stepping onto a curb or even stepping over an item or avoiding something on the ground. So we'll kind of use the information we gain from our assessment to then focus on some of those different areas and help patients understand how to weight shift, how to react to different balance challenges, and ways to help them understand strategies to also regain their steadiness. And we may progress towards walking on uneven surfaces, which is needed for if you think of going outside on gravel, or if you're on a hiking trail where there might not be a concrete path, but more uneven dirt and roots and stuff that we might try to work on. Mimicking those things in the clinic to help somebody be safe and independently navigate those things when they're out in the community. And then we also might do a variety of tasks where we have the patient close their eyes when they're doing the standing balance. Again, all of these things we would be guiding in the clinic and is safest to do with a physical therapist, but are certainly ways that we can help people improve their balance overall. And then we also have patient education that we will continue to focus on really throughout the whole time that we see a patient, but are ways that we discuss management for neuropathy, one of which includes good skincare, so protecting the hands and feet, thinking of having good hydration on the hands and feet using, like I said, a gentle lotion. And then also protecting the hands and feet if you're dealing with items, wearing gloves, such as with washing dishes or gardening, and also if you're using other chemicals, just being careful, because if we've tested sensation and somebody isn't able to feel what we test, then again, we want to take extra care to avoid cuts and scrapes if somebody is not really able to feel if something injures their hand or foot. We'll also work on relaxation techniques. So I included here the image of this person doing some deep breathing. That can help, again, kind of calming the nervous system and helping to decrease pain as well. Other things might include environment adaptation. So we could think of if somebody's having more difficulty getting around, using things in their home like grab bars or having railings by the stairs if they have stairs or steps, having a shower chair or bench as well. Because if somebody's having difficulty standing, if you add on that the slippery floor potentially in the bathroom, as well as closing your eyes for doing hair care, we may see that it's safer for some of these folks who have difficulty with their balance to be seated while they're showering, but still independently be able to bathe themselves. Again, kind of tied into that is different things that we would discuss to help prevent falls. So making sure there's not rugs that are loose and able to be tripped over, or just clearing the floor, that there's no clutter around, using good lighting, different things we would discuss again in the clinic with patients and help drive home those ideas of ways to help prevent falls. And then some other things that patients can do are reducing alcohol consumption. Some people can develop neuropathy specifically from drinking alcohol in excess, but generally speaking, alcohol consumption should be reduced to help reduce symptoms from that, as well as for cancer outcomes. Reducing alcohol intake can be very helpful, and stopping smoking as well, because we know smoking can help, or sorry, smoking does not help. Smoking can decrease the body's healing capacity. So those are two things that are more behavioral things, but things that people can stop doing that can help their body heal faster. And then we may also discuss in physical therapy some options for different assistive devices. So you might think of a cane or a walker. I sometimes will also suggest patients try using hiking poles or trekking poles, because those can also add a little bit of steadiness for people and can help with energy conservation, as well as helping somebody stand upright a little bit more. So just a couple of different options of things that we might look at and try out in the clinic as well. I included here the resources that I looked at, some from the National Cancer Institute and American Cancer Society, as well as a handful of the articles I used here. And then I will turn it back over to Archana for some questions and discussion. Thank you all for listening, and I appreciate the questions you submitted beforehand and during the presentation.
Thank you, Stacy. That was great information, and I especially liked your explanation about why it is caused, because we did get a lot of questions about why does chemotherapy cause peripheral neuropathy. So yes, we did receive a ton of questions, and we did get a lot of questions specifically about radiation-induced nerve damage. So Stacy, is there any research about radiation-induced nerve damage? Or any information on that, because we got a lot of questions about that.
Yeah, so we know radiation-induced neuropathy is more rare than the chemotherapy-induced neuropathy, and it doesn't happen quite as quickly as we see with chemotherapy-induced neuropathy, or not quite as closely. Sometimes the radiation neuropathy can happen years after a person has received radiation. But again, it will still potentially be that numbness and weakness and pain, but it is more dependent also on the area of the body where the person received radiation. So for an example, if somebody has radiation for breast cancer, they may receive radiation on the chest near the breast, as well as near the neck and lymph nodes that are up higher. And we have nerves from the peripheral nervous system again that extend down into the arm, and somebody could have some impact here, and that might be noticeable in their arm or in their hand where they're having issues. And it might not be that same appearance that we see with CIPN, because we see that more on both sides, so left and right sides, versus radiation again will be more dependent on where the radiation is delivered. They don't know the exact cause, but there's some association with reduced blood flow to the area from the radiation, damage to the nerve itself, and sometimes compression or pressure on the nerve from the area that was radiated.
So regardless of the cause, if there is any physical impairment, weakness, there's still ways for PT to be able to address that.
We would use similar techniques. It might vary again a little bit on some of the anatomy where it was located, but we can certainly work on strengthening, desensitization, some of those things if we need to adapt the environment for the person. All of those things we can certainly work on in PT and potentially OT depending on the presentation.
Do you have any advice for running with neuropathy in the feet?
So for somebody who potentially was running before treatment, or even if somebody's interested in after, we would definitely want to evaluate the person's safety, as well as the extent of their neuropathy, and then look at different types of footwear that they might wear, and help them kind of progress. If they are just trying to start out again, we would potentially try doing like different components as well as strengthening to help the person be safe when they are running. A very unique approach to it all because everybody's different.
Different, yes. Do you have any idea why African Americans may have more and seemingly worse chemotherapy-induced peripheral neuropathy than other race or ethnic backgrounds?
So there's definitely ongoing research about how neuropathy is different in different people and different groups. But for our current understanding, we believe there's different disease biology. So what exactly is happening with the cancer, and the impact it has on the body, as well as different risk factors for different groups of people. And then even different response within the body to a specific chemotherapy. So with the Simon Cancer Center, we do have some ongoing research about how certain drugs how are they causing different reactions for patients as well. So still to be determined, but we know there are unique differences for people of different backgrounds right now.
There's a question asking where there might be contact information or where they can find a massage therapist that focuses on, say, post-head neck cancer treatment or fibrosis of the neck.
Yeah, so I'm a little more familiar with rehab clinicians who do this. We have here at the clinic that I work at an occupational therapist who does treatment for head and neck cancer, including lymphedema, fibrosis, kind of like hardening of the tissue that can be treated. And we do have somebody here who does that.
So because, I mean, fibrosis, I mean, it can be painful, it can cause a lot of functional, problems. It probably is best before going directly to a massage therapist to have it evaluated by an occupational therapist or, someone who understands the lymphedema side of things as well as the actual impairments of it. That's
definitely
helpful. I was going to ask one more question, and you did refer to some of this about, when you spoke about what can we do to delay or prevent. So there's a specific question asking if use of icing protocols during chemo infusions can delay or prevent CIPN.
So there's also ongoing research about that. From one of the systematic reviews that I looked at that mentioned this, they discussed how when they have studied this, not a lot of patients have gone through the entire study and did ice therapy or cryotherapy on their hands and feet the whole time they received treatment. So it's hard to say because some patients kind of dropped out of the study. This is something that the patient should discuss with their oncologist to understand if it's appropriate for them to do. Some patients might not be able to tolerate having the ice on for the entire duration of their chemotherapy infusion or other infusion therapy. So this is something, there's ongoing research. There's not a great recommendation for it right now, but is something that if somebody is interested in, they should discuss this further with their medical oncologist and make sure that it's appropriate for them and where they are in their treatment. So unfortunately, I don't have a direct answer. And the research that we do have is limited because a lot of patients drop out of the studies because it's a harder thing to do to maintain ice on your hands and feet while a person receives an infusion. And infusion times vary as well based on the drug somebody receives or the multiple drugs somebody receives. So we don't have great clarity or recommendations right now for that, unfortunately.
I think we might have time for one more last question, and thank you for sending questions through the chat. We have one, what type of exercises are good to build your strength in your feet, even if you have no reflexes below the ankle? This individual has difficulty feeling their feet and have difficulties like getting up from a squat up to standing.
Yeah, so even knowing that, there's a lot of stuff we can do with a person sitting like in a chair or even laying down. There's exercises, and even laying on a bed is the position I'm referring to. But that we can work specifically at the ankle and foot on moving the foot up and down, going out to the side, back and forth, even things like drawing the alphabet with your toes to kind of make the foot go in different directions. And then, like I said, exercises where the person's sitting, that we can work on hip and knee strengthening. Even if somebody has issues where they can't feel reflexes, then we would want to try to strengthen everything that they do have, and maximize their strength in other areas, even if we might not see them get fully back to where they were beforehand. We want to try to get people as strong as possible to help them move around. And in a case like that, we would evaluate somebody if we thought they might need an assistive device, so something to help them get around a little more safely. And one of the other things I talk very regularly with my patients about is doing daily foot like skin checks. So either when you're getting dressed for the day or when you're removing socks or shoes from your feet, checking the skin in that area, especially if you don't have reflexes. From the question, I don't know if they had numbness at all, but if they can't feel that portion of their foot very well, that's something you want to visually inspect to make sure there's no cuts or scrapes or anything like a rock or something that you stepped on and you can't feel in your foot. So those are some of the strategies we would use where we would help teach the patient things to do. And again, try to help make them independent with like the home exercise program that we work on, and using strategies like an assistive device. We would try to do some other activities to help really just improve your understanding of what do you feel and what don't you feel, and just help you be as strong and independent really as possible.
All right. Well, thank you, Stacy, for all of the information and also for answering the questions. And I thank you all for joining us this month. And a recording of this will be available of today's session and the information at cancer.iu.edu/Simon Says. And there will also be information about upcoming educational series. So thank you again and have a good afternoon.
Thank you.